So again, we have a case to discuss here. There are two causes of stiffness in our country following supracondylar fracture. One is massage, and second is the surgeon. And whichever way you manhandle the fracture, it's going to get stiff. So this is a case where you see both the examples in one. So this is a 14-day-old fracture, and presented with this to a surgeon. Keep your voting pads ready, and I want audience response on this. How will you treat this? Will you just immobilize, allow it to mal heal, and do an osteotomy if required later on? That's the first option. Second is open reduction and internal fixation. Open it, align it, and fix it. And third is close reduction. Try intrafocal or whichever method, and get best alignment and fix. Yeah. Okay, so it's a fractured mandate. So everyone feels differently. And what was done for this patient by someone was open reduction and fixation. And as Sandeep has shown, you get stiffness because there is a lot of swelling around, there is myositis, and that results in stiffness. This is at 2 months. And you can see that there is some fluffy calcification here, which is telling you that probably this is the cause for stiffness. And when that happens, people go to physiotherapist, and some people who don't believe in physiotherapists go to some people who are more qualified therapists who will probably got their joint to bend more. And this patient went to a person who, of course, got his joint to bend more, but then he couldn't extend it at all. This is what happened. And what should we do at this situation? What's the cause for this stiffness? And we want to ask James. James, does this happen in Singapore also? And what would you do now at this stage?
Oh my God. Send to your best friend. No. Then we actually start this. The neurologist actually helped me to start giving all the medication, and also we have an anesthetic unit who are also interested in this. So then gradually start to get more range, but it's a very challenging thing to have.
Right. So we gave endomethacin to this child, immobilized for a while till the time all the swelling subsided, and gradually home therapy was started. This time alkaline phosphatase was 11220, very high. So he had now fractured ulna. There is severe myositis anteriorly as well as around radius and ulna, which caused a lot of stiffness. This is after 3 months. Now you can see that myositis is maturing. There is radioulnar cross union, which is preventing your pronation and supination. And then there is a myositis along the brachialis, which is not allowing the elbow to flex. And then there is, newborn formation in the olecranon fossa, which is not allowing it to extend. So all this could have been avoided if the patient was allowed to malunite, and one would have done an elegant supracondylar osteotomy the way Viraj did yesterday, and corrected all deformity at a later date. What should we do now? I'm going to ask Premal at this stage, with this, what would be your approach now? How do we tackle this at this stage?
I think we have to not take off the bone which is impaling his function,
right,
in the best possible way without damaging. And I think it will be a nice idea to start endomethacin as soon as we start.
So that was started already.
Yeah.
So what we did was, there were two problems here. One is the myositis, which is anterior, myositis, which is between radius and ulna. So we did dual approach. One was a ulnar approach through which we took out the myositis in the brachialis, and then we took a Boyd's-like approach posterolateral through which the myositis between radius and ulna was removed. This was done after doing a CT scan, and this is a post-op X-ray, and this is almost after 3 months post-surgery. He's got good range of movement and pronosupination, and ultimately you can see he's smiling but still suspicious of doctors. Thank you.